For newly diagnosed patients with follicular lymphoma, there are a number of factors that need to be taken into account when making a decision about initial therapy. The major classes of therapy to consider are single agent rituximab for those patients who fall into the low tumor burden group, those patients typically who do not meet GELF criteria for treatment. Those factors that are considered in the GELF criteria are having a single lymph node that is bigger than 7 centimeters, having 3 or more lymph nodes, each of which are bigger than 3 centimeters, having evidence of B symptoms, having a large spleen, having a high white blood cell count, or having effusions in the pleural space or peritoneal space. So for those patients who fall into the category of having no GELF criteria with advanced stage follicular lymphoma, the use of single agent rituximab can be appropriate, or observation can be appropriate for some of those patients as well. Observation has been the standard approach that we use for those patient populations because there has never been a randomized controlled trial that has shown that overall survival is improved by early intervention for patients with follicular lymphoma. For patients who fall into the other category of high tumor burden by those GELF criteria, the considerations should be chemoimmunotherapy with a variety of regimens. Those include rituximab plus CHOP chemotherapy, rituximab plus CVP chemotherapy, rituximab plus bendamustine, or alternatively, another monoclonal anti-CD20 antibody, obinutuzumab plus CHOP, obinutuzumab plus CVP, or obinutuzumab plus bendamustine rituximab. There now have been randomized controlled trials that have shown that bendamustine plus rituximab has improvements in progression-free survival over R-CHOP, and another trial that showed that those two are equivalent. And because the toxicity of bendamustine is less in general than R-CHOP, bendamustine rituximab has more commonly become a standard frontline regimen for patients with follicular lymphoma. Given that there is no hair loss associated with that, there's less risk of anthracycline toxicity associated with that, including cardiovascular disease. The other alternative that is now available is the use of lenalidomide plus rituximab. There now have been randomized controlled trials, notably the Relevance trial that looked at lenalidomide plus rituximab versus rituximab chemotherapy with each of those chemotherapy regimens that I just mentioned. In that randomized controlled trial, that trial has become known as the single most positive negative trial. So the intent of the trial was to show superiority of lenalidomide rituximab over rituximab chemotherapy. The trial failed in its primary endpoint to show a benefit in terms of CR30, so complete response rate at 30 months with a benefit over rituximab and chemotherapy. But those two forms of approaches are relatively similar in terms of their progression-free survival, with lenalidomide plus rituximab having different side effect profile than chemotherapy, but not the same kind of chemotherapy related toxicities that are commonly seen with R-CHOP and bendamustine rituximab. So there's now potentially the availability of a chemotherapy-free regimen in the front line for follicular lymphoma.